Welcome to this explainer. Today, we're exploring one of the most intense, high-stakes environments on the planet, the mind of a surgeon. Whether you're a medical enthusiast or you just kind of want to understand what's actually happening when someone gets rushed through those ER doors, we're going to completely deconstruct the clinical reasoning behind surgery. I mean, how does a surgeon decide, in a split second, who needs an operation right now, who just needs a scan, and who simply needs observation? The margin for error is razor thin, and these decisions are rapid fire.
To really see what I mean, let's look at a dramatic life or death scenario straight from our source material. Imagine a 60-year-old guy is rushed into the emergency department. He's got severe retrosternal chest pain, so intense pain right behind his breastbone, plus he has subcutaneous emphysema. That's when air gets trapped under the skin, and it literally feels a bit like bubble wrap when you press on it. And all of this started right after a massive bout of forceful vomiting. Put these clues together. If you're the surgeon on call, what is your diagnosis?
If you guessed Borhave syndrome, you hit the nail right on the head. This is a life-threatening, full-thickness rupture of the esophagus, and a surgeon's reasoning in this exact moment has to be incredibly precise. They know that a ruptured esophagus is going to rapidly leak stomach contents directly into the chest cavity, leading to fatal mediastinitis. Recognizing this pattern instantly dictates aggressive, immediate intervention. There is absolutely no time for a wait-and-see approach.
Okay, let's dive into this playbook for how real surgeons think, triage, and ultimately treat. We're going to break this down into 4 phases. First, assessing the immediate threat. Second, solving the diagnostic puzzle. Third, answering that ultimate question, to cut or not. And finally, managing the surgical aftermath. Starting right off with phase 1, assessing the immediate threat, or the golden rules of triage. Because before a surgeon can fix a specific problem, they have to ensure the patient is actually going to survive the next 5 minutes. Let's test that logic with a multi-system trauma puzzle from our sources. A 30-year-old guy is brought in after a bad high-speed car crash. He's got a decreased level of consciousness, which is a glaring sign of head trauma. But his abdomen is also tender and guarding, heavily pointing to an internal bleed in his belly. You've got a brain injury on one hand and a bleeding abdomen on the other. Which one do you prioritize right this second? Take a quick second to think about it.
Well, the clinical reasoning here is sequential and it is absolute. Step 1 is always securing the airway and breathing. You absolutely must intubate and mechanically ventilate this patient first. Why? Because preventing hypoxia, oxygen starvation to the brain, completely takes precedence over rushing to fix the abdomen. Once that airway is locked down, then you move to the emergent laparotomy to open and fix the belly. Airway always beats circulation, period.
And this brilliantly illustrates a core concept in surgical reasoning: hemodynamic stability. Look at 2 wildly different scenarios. If a patient comes in with an upper GI bleed, but their vitals are totally stable, the surgeon's first move is actually medical. They get IV fluids and a proton pump inhibitor infusion. But if a patient rolls in from a car crash with a suspected pelvic fracture and they are hemodynamically unstable, the reasoning shifts instantly to physical intervention. They get an emergent pelvic binder slapped on to stabilize the bones and stop the massive bleeding before they even get near a CT scanner. Stability dictates the speed and the type of weapon a surgeon uses.
So once the patient is stable, we enter phase 2, solving the diagnostic puzzle by gathering the clues. This is where clinical reasoning starts to look a whole lot like detective work. Let's see if you can spot this classic pattern. A 70-year-old male who's a heavy smoker comes in complaining of back pain. During the physical exam, the surgeon feels a pulsatile mass in his abdomen. It's literally beating like a heart, right where a heart definitely shouldn't be. What is your next step?
If you're the surgeon, you immediately suspect an abdominal aortic aneurysm, or AAA, and you order a CT angiography. The reasoning here is that different clues require highly specific tools. A CT angio is the absolute perfect tool for mapping out the size of that aneurysm. But say the surgeon is feeling a firm breast mass, the tool of choice shifts to a core needle biopsy to get a good look at the tissue architecture. For a thyroid nodule, they'll start with a fine needle aspiration. And a lower GI bleed? A colonoscopy lets them actually see the bleed and clip it right then and there. Clinical reasoning is all about matching the specific pathology to the perfect diagnostic tool.
Which brings us to the climax of the decision tree, phase 3. To cut or not. You know, it's often said that the hardest part of a surgeon's job isn't knowing how to operate, it's knowing when not to. Let's contrast 2 different patients with gallstones to find that exact threshold. Patient A has uncomplicated biliary colic. Basically, they get episodic pain after they eat.
The surgeon's choice? Observation and dietary modifications. Put the scalpel away. But patient B has acute gallstone pancreatitis. A gallstone has actually blocked the pancreatic duct, triggering severe, life-threatening inflammation. For patient B, the reasoning completely crosses the threshold. They need an early cholecystectomy, meaning removal of the gallbladder, during that very same hospital stay so this doesn't happen again.
Now, what's really interesting about this slide is how identifying the underlying root cause dictates the surgical fix. If a patient has acute pancreatitis, taking out the gallbladder only makes sense if gallstones are the actual culprit, which, by the way, they are in about 40 to 70% of cases. But if the pancreatitis was caused by alcohol consumption or high triglycerides, removing the gallbladder wouldn't fix the underlying problem at all.
Sometimes, though, the decision to cut relies on catching a massive red flag. And here's a vital pattern recognition phrase that every single surgeon knows: pain out of proportion. Picture a 70-year-old man with a history of atrial fibrillation and irregular heartbeat. He is screaming in agony, saying his belly hurts beyond belief. But when the surgeon presses on his abdomen, it's actually relatively soft. The physical exam just doesn't match the extreme level of pain. So what's happening here? The answer is acute mesenteric ischemia. Because of the patient's irregular heartbeat, a blood clot formed, traveled down, and completely blocked off the blood supply to his intestines. His bowel is literally suffocating. Think of it like a heart attack, but in the gut. It is incredibly painful, but because the damage starts on the inside of the bowel wall, pushing on the outside of the belly doesn't cause that much extra pain. Recognizing that specific phrase, pain out of proportion, is a blaring alarm telling the surgeon they must operate immediately to restore blood flow before the tissue dies. Furthermore, once the decision to operate is actually made, the precise location of the disease dictates the specific technique used. Take these two cancers, both involving the large intestine. A localized colon cancer generally just requires a standard surgical resection to get oncologic clearance. But if the cancer is located just a little further down in the rectum, the standard of care totally changes to a total mesorectal excision, or TME. This is a highly specific technique aimed at complete removal while painstakingly trying to preserve the delicate sphincter muscles. The geography of the disease completely dictates the geography of the surgery. Now, you might think the surgeon's job is over the second the incision is closed, but clinical reasoning continues well into phase 4, managing the surgical aftermath. Check out this classic post-op puzzle from our source material. A 65-year-old guy just had his gallbladder removed. On the third day after surgery, he spikes a fever. Naturally, your first thought is probably, oh no, the surgical wound is infected. But the surgeon checks the incisions and they look absolutely perfect. No redness, no pus, nothing. So what is the most likely cause of this day 3 fever? So the crucial point is that post-operative fevers are very often respiratory, not surgical site infections. The answer here is atelectasis, which is an incomplete expansion of the lungs. Because the patient was knocked out under anesthesia and is probably guarding their sore belly, they just haven't been taking deep breaths. This is a super common cause of fever on days 2 through 4. And the crazy part? The treatment isn't some heavy IV antibiotic. It's literally just getting the patient to cough and take deep breaths. But what happens if the wound actually is failing? Say a patient's abdominal incision starts to separate, a condition called wound dehiscence. The knee-jerk reaction might be to just grab a needle and quickly restitch the surface. But a surgeon's algorithm dictates a much more crucial next step. You must perform a thorough wound exploration. You have to look deeper. Why did it fail? Is there a hidden infection in there? A hematoma? If you just blindly stitch the surface closed without fixing the root cause, the whole situation is going to get a lot worse. Wow. We have followed the surgeon's decision tree all the way from the chaotic initial triage, right through the diagnostic puzzle, into the operating room, and finally into the recovery ward. You've seen exactly how algorithms, pattern recognition, and strict logical sequences govern absolutely every move they make. So I want to leave you with this provocative thought. If you were presented with a single symptom right now, how sharp is your clinical reasoning? Are you ready to look past the obvious and find the hidden threat? Thanks so much for joining me on this explainer, and to all of you out there, keep that focused learner mindset sharp. You've definitely earned it.